Good morning, good afternoon, or good evening. My name is Mary Napolitano. I have been working as a product manager here at Standard Imaging for our patient QA solutions for about a year now. So here are some of my colleagues at Standard Imaging. Standard Imaging employees during these challenging times are proud to be helping with your radiation calibration and quality assurance needs. So let's go over a bit of housekeeping before we get started. Today's webinar will be recorded. Please enter your questions at any time during the presentation in the GoToMeeting dialog box. I will answer all questions at the end of the presentation. Standard Imaging is based in Middleton, Wisconsin, and was founded in 1989. We design and manufacture a full suite of QA products. So, in general, there are many different types of plan-specific checks that are performed. One can perform a pre-treatment plan check using, for example, a calculation-only second check, as well monitor unit checks. One can use detector arrays, EPIDs, log files, many different variety of checks. There's also, of course, besides pre-treatment, we can do during treatment QA. Employ, for example, EPIDs and log files. In this area, one can determine some LINAC variations from the plan using log files, and EPIDs can capture other LINAC variations as well as patient-specific setup or anatomical changes. For an overall view, end-to-end testing is very important. Multiple presenters at this past summer's virtual AAPM annual meeting suggested that with increased complexity of treatment workflow, that physicists should consider performing end-to-end testing on a more regular basis rather than just when starting a new program or commissioning a new system. So what is typical varies from clinic to clinic, as well as regional differences due to available staff, budget, regulatory requirements, and/or billing-related issues. So when taking all of these into consideration, which types of patient-specific plan QA is best suited to your clinic? As physicists, we want to catch and allow for correction of minor workflow issues that may have crept in systemically, as well as one-time minor workflow issues. And of course, always catching the major mistreatment, potential mistreatment errors before they occur. With the increased attention for probabilistic risk assessment as recommended by the AAPM Task Group 100, we can continue to improve accuracy and precision in delivery of patient plans. Standard Imaging has a variety of products to help perform patient plan-specific QA. My goal during this presentation is to outline at a high level what sorts of discrepancies are being caught by each of our products and what parts of the process are being checked by our variety of products. IMSure provides a quick and easy basic second check calculation. LinacView is an automated log file-based plan comparison software. Adaptivo contains modules for pre-treatment and during treatment QA, both using EPID images, and Adaptivo also has an automated independent adaptive dose reconstruction module. The stereotactic dose verification Phantom and Lucy both allow for end-to-end testing. So as I go through the presentation, because I'm a visual person, but unfortunately without a lot of artistic talents, I put together this workflow chart to keep track of the portions of the workflow touched by the different plan-specific QA patients that we can combine to review all of the different steps throughout the workflow. And this slide, I'll repeat it as I go through each of the different solutions, and I haven't been all inclusive, but it will just give you an idea visually which portions of the workflow are touched by different specific solutions. So, just take you briefly through it. The commissioning data from the LINAC and the CT are, of course, put into your treatment planning system, as well as the patient setup, imaging, contouring, and the plan prescription. So the patient-specific information going in. The plan, of course, then is sent on through for perhaps a step for a pre-treatment measurement, either via log files, EPID images, or other independent measurements. Of course, we have the dose that we can come in and compare. And then, working our way down to the patient alignment prior to delivery. And so you get the cone beam CT at that point in time, which we can use in some of our QA, and as well when the patient is actually on the table during patient treatment. And of course, we again have the log files, EPID, RT records, as well as certain independent measurements can occur. So our first solution I'm going to touch on in a little more detail is IMSure. It's a very simple and quick second check software, but it's independent. This software contains 4 calculation modules. So the MU module, which is your basic hand calculation, assuming a single source, and then we can get more complex plans using the QA module, things such as VMAT and IMRT, 3-source model to include some additional scatter, and CyberKnife and the brachytherapy modules are also included. And so what advantages does this sort of solution have? It provides an independent calculation of dose points for a wide variety of modalities, including brachytherapy, CyberKnife, and LINACs from all the major vendors. So a lot of your QA needs are covered here, and it provides a good independent check. So where does this fit into the workflow? So the second check of your treatment planning dose has a separate beam model created with different data. And so we, of course, commission data for IMSure's beam model, be it a LINAC or, the brachytherapy source model representation using the TG43, as well as the CyberKnife. So we have that specific beam data going into IMSure. And so you can consider that a verification step. But then, of course, all of this plan-specific information and the RT plan created in your TPS then, of course, is exported to IMSure to get that independent second check, creating your report, sending that back up to your R&V system. Now, if, for example, you send your plan from the TPS system onto your record and verify system, that extra handshake along the system is checked. And then rather than exporting directly from the TPS, you can export from the R&V system. So that extends the area of the workflow covered a bit further. And you can see the QA is just covers a certain area of the delivery workflow, but you can extend it. So what other solutions should we consider? So the next one is LinacView, and this is a log file-based system that extends your plan-specific QA through the LINAC delivery. The workflow is as follows. The RT plan is again exported from your treatment planning system directly to LinacView, and at the same time is exported through the R&V system through to LINAC delivery. LinacView has a system that listens for the log files and continuously in the background, once installed, analyzes those as they are received. LinacView takes this measured data from the LINAC in the form of log files to compare to the RT plan. The log files contain such information as leaf and jaw positions, monitor unit, gantry angle, collimator angle, and couch position. These data can then be compared with the original plan via deviation and fluence map comparisons for leaf and jaw positions in monitor unit. Direct comparison is made from expected for gantry, collimator, and couch positions. And so this is a very direct comparison. The software runs in the background and provides audible or email alerts based on customizable failure and alert criteria. And then another point with this system is that highly modulated complex plans are most likely for the LINAC, most difficult for the LINAC to deliver, and they have been documented to be most likely to fail plan QA. And here, this is a very direct method to analyze how closely the RT plan and the LINAC delivery are being matched. So the solution covers an additional portion of the workflow, but you must be aware that one must keep up with machine QA, as there are cases during which a log file analysis will not catch all delivery errors. Things such as slipping motors and inaccurate leaf positioning sensors cannot be detected through log files. However, with frequent MLC calibration and regular machine QA, for instance, these gaps can be minimized. There are many advantages to offset the limitations, such as the automated patient plan QA with minimal user intervention. As already mentioned, the log file fluence is compared to plan fluence. You get quick confirmation that the correct RT plan has been transferred and delivered. You get the results very quickly before the patient even leaves the room. And there is a record, a verification, independent verification of correct treatment for all fractions. And then, it's convenient because it's compatible with all Elekta and Varian LINACs. And our latest release even extends to the Elekta MR LINAC, the Unity. So now you can see that the QA touchpoints designated by the light green encompass a much larger portion of the entire workflow. The loop can even be completed for cases in which you have a concern or an alert was found, and you can generate an RT plan based on the delivered fractions and import that back to your treatment planning system to get a comparison of the RT plan generated from the log file information and compare that to the original RT plan that one desired to deliver. So you can get some specific dosimetric information back through this workflow. So you can see it goes through a large portion of the treatment workflow. So the next complementary solution is Adaptivo, which has modules for pre-treatment and during treatment comparisons, which are both 2D using the EPID imager, and a third module, which provides for independent 3D adaptive patient QA based on the daily cone beam CTs. And I'll go into those modules in a bit more detail. The pre-treatment module verifies plan transfer and delivery using the EPID measurement in air. It also verifies the RT plan by comparing the calculated to the predicted image. The physicist then receives automatic alerts if the verification has a failure or is close to failure. The next module is similar to the pre-treatment module, but the portal image is measured with the patient in place in order to verify patient setup consistency. This comparison is done using a gamma analysis based on the predicted exit image and the measured EPID image. Proper couch placement and selection can be verified, which is a QA that's not possible with a log file only solution. Next is the adaptive module. This module uses daily and cumulative dose color watch and DVH to compare to the planned data. The DVH is automatically analyzed using preset Quantec limits and RTOG protocols, so you can see if you are comparing well to the standards of care. Of course, you can adjust these protocols if you want, but that's another verification check. The system is fully automated such that Adaptivo detects when a new treatment has been delivered and performs complete analysis. There's a clear and informative dashboard which shows alerts and deviation based on the planned daily and cumulative metrics. These notifications are based on user preferences and can be received via email or reviewed in the Adaptivo dashboard. So, along with automated data collection and analysis and notifications, Adaptivo allows for the verification of daily patient setup, anatomical changes, and delivery. The software also provides metrics to determine the appropriate time to replan and is an independent adaptive QA solution. And here is where the Adaptivo fits into the patient workflow. You can see it, covers the entire workflow. There are Goldbeam data models input into Adaptivo, as well as the EPID measurements. Down through the pre-treatment QA, you can do pre-treatment based on the EPID images. And of course, when the patient is aligned, the cone beam CT is integrated into Adaptivo. And we also have the EPID images and RT records coming at the time of the planned delivery. And of course, there's always reporting for your verification. So moving on, the Lucy Phantom is a gold standard used for end-to-end testing for the entire stereotactic treatment chain. Precision manufacturing allows the user to verify cumulative uncertainties of the treatment chain to within 0.1 millimeter accuracy. This is accomplished by using a variety of inserts that I've shown here. The inserts have precisely known volumes, geometries, and distances for accurate measurements. And the Lucy then is put through the same processes as the actual patient, which means that the Phantom will be scanned on the CT and or MRI and to start this treatment chain. We have separate sets of inserts for MR and CT. For CT image QA, we have marker cylinders, irregular volume inserts, CT densities, and a distortion grid. The CT densities are great spot check. The MR inserts include matching marker cylinders filled with mineral oil, matching irregular volume insets, MR signal generator, and MR distortion grid. The marker cylinders for CT and MR have known distances, and the irregular volume inserts have known volumes. So verification of image fusion is also possible using the MR and CT inserts. The advantages of Lucy are numerous. Various inserts allow for verification of target and avoidance structures for the treatment planning system, along with testing contours and volume accuracy, image transfer accuracy, verification of TPS dosimetry through detector and or film measurements. TPS limitations for small fields can be determined and verified using the Lucy, as well as verification of accessories and couch modeling, and verification just of the overall entire process. So for cases, though, not involving brain lesions, but with larger tumors in other organs, typically the lung, standard imaging provides an end-to-end testing solution in the form of the stereotactic dose verification Phantom, the SDVP for short. Similarly to Lucy, this Phantom has water equivalent and lung equivalent material slabs. The respiratory gating platform, RPG, is a simplified platform that independently controls the range of motion of the respiratory cycle. The X-rate in A26 W2 scintillator and diodes are optimal, and specific inserts are designed for using these detectors in the SDVP. And these detectors are then used in conjunction with the Supermax electrometer. And this shows the lung equivalent density slabs, and the blue is the water equivalent, so gray is lung equivalent. Overall, the SRS dosimetric QA insert provides complex geometric targets with bone equivalent density material to evaluate image avoidance and inclusion components of the treatment planning system. The volume of the test objects are known and can be used to evaluate the volumetric accuracy of the treatment planning system, as well as the independent CT density checks. So overall, the SDVP is versatile and compact. Since these pictures are small, you can't tell, but this is a 20 by 20 Phantom. And as seen here, there are at least 4 different standard configurations that one can choose from. There are embedded gold and lead fiducials within the Phantom, as well as laser alignment markers to allow for orientation and positioning accuracy. Our chamber plug with gold marker can be used for smaller tumors. In various inserts, you will notice components similar to those I already went over for Lucy. The advantage including verifying dose positioning accuracy, volumetric accuracy, inserts for verification of CT density, and verifying dose accuracy in a heterogeneous material. And I'm sure I'm missing a few. So as Lucy and stereotactic dose verification Phantom are both end-to-end Phantoms, I've grouped their workflow together here. Clearly, these Phantoms cover multiple verification aspects from the imaging system through to verification of the dose in the heterogeneous material. So that concludes my high-level overview of the multiple patient plan QA related solutions. And if you have not already done so, please type any questions that you may have into the GoToMeeting dialog box. For more details on any of these solutions, please feel to reach out to me or your sales representative. And now let me take a look and see if we have any questions. But let's see, have you created plans with known offsets to stress EPID pretreatment measurements versus a 2D or 3D array? I have not. And I can check and see if I can find indication that others have done so and let you know. Is LinacView comparison based on comparison of beam parameters, or does LinacView do a recalculation using the log file parameters? It's just log file parameter based, so it's fluence only. So it doesn't compute dose, if that's, I believe that's the question. Please outline the main differences in the use of LinacView versus Adaptivo. So LinacView is log file only based, and it's fluence based. All the comparisons are going to be 2D, so you're comparing the, I would call it the desired plan, the perfect plan, the ideal plan, to what was actually delivered on the Linac based on the leaf and jaw positions and the monitor unit delivered. And so that is the comparison basis, whereas Adaptivo actually, is a different sort of measurement. It's, the EPID measurement for the 2D comparisons. And so then you can, of course, since for the cases in which, the patient is on the couch, then you can see your setup differences. For example, if the patient isn't aligned properly, and you can also determine if it's, as time goes on, variation in the patient anatomy that you can determine using the 2D gamma analysis. So it's more comprehensive, and it includes, of course, any differences in the delivery as well as differences in the patient. So sometimes it's difficult to distinguish between those, and that's why we call them complementary, because LinacView is going to let you know the specific machine delivery differences, and then Adaptivo for the 2D portion adds the patient setup differences, and you can use them in a complementary fashion. And then, of course, the 3D adaptive is a whole different module that gives you an indication of the 3D volumes and the changes to those volumes throughout patient delivery based on the daily cone beam CTs. So that's I guess a much different and much more detailed view. But with the 2D, they're complementary, and then with the 3D, it's an independent adaptive view. Can you tell me more about log file QA for Unity? So it is a bit different workflow, and we could talk in more detail later. But since the Unity has an adaptive workflow, so each day you have a plan of the day, right? And so each day that the patient is on the couch and is being imaged, and then the plan is generated with the patient, of course, still on the couch, so you can't do the traditional pre-treatment QA. But when you are complete with the plan, you can go ahead and send that plan when it's sent to the LINAC at the same time to LinacView, and then you can get before the patient even leaves the couch, the comparison for that daily plan. And then each day you can close out the plan, and on the next day you can have a real quick comparison of the fluence predicted by the treatment planning system and predicted from the log file, MLC positions and monitor unit positions. Let's see, hello, Hyder. How do you identify the problem that the plan is due to deviation or due to dose computational algorithm errors? So I'm not sure which component this question is associated with. So I am going to, I guess, assume that this is associated with Adaptivo because it is the only of the solutions I spoke about, the only solution that has the independent dose algorithm. Well, of course, IMSure does, but that's a much more simplistic algorithm. And that's a really great question. And that's why I think that you can look at many different solutions in combination that can answer different questions for you. I really like the log file analysis because that really hones in on delivery differences as long as you're doing your machine QA accurately. I also like of course, the end-to-end tests so that you can look at those deviations with some very accurate detectors at specific positions. And that gives you a good comparison, for example, with the using the W2 with the SDVP in the lung material insert. That gives you a great comparison, for example, between a Monte Carlo algorithm and a convolution superposition. And so you can tease out the deviations using a combination of these solutions. And those are all of the questions I see. Thanks for all the questions and your attention. And if I have not answered the questions well, please let me know, and I will. I can follow up via email. Thanks, and have a great rest of your day.